Welcome back to another Gait Geeks podcast. Ivo and I are going to talking all about Hallux Dorsiflexion today, so stay tuned. Hey guys, welcome back. Like I said, today Ivo and I are going to be talking all about Hallux Dorsiflexion and specifically reviewing an article. Ivo, how are you?
I am well. It is very snowy here in Colorado and cold. We just had about 2 feet of snow and it came back from the Keys and it was very cold.
Tell you
A
what,
lot of stuff to move, but it was good.
We don't have any snow up here in northern Florida, but it's been a little bit chilly myself. I got my sweatshirt on. Us Floridians, when it gets below like 50, bundle up. And today it was in the 30s for a little bit. So I wasn't like
Yikes.
it was not fun for me. But anyway, welcome to everybody back to our channel here. Today again, we're going to be reviewing an article. The article specifically we're going to be reviewing is this one right here. So Ivo, why don't you take over and just kind of give us a little bit of a run into what we're going to be discussing.
So Hallux dorsiflexion is super important because first MTP pain is something that we see a great deal of in the office. I thought this was interesting because it uses a product called the kinetic wedge, which is basically a reverse Morton's toe extension, which we'll talk about. I think Scott's got a picture of it on here somewhere as well. What these particular people did is they used this device, which basically drops the head of the first down into the ground, and it decreased the amount of force needed to dorsiflex the first MTP joint. And we know
it was actually about a 40% reduction, actually 39% reduction.
It was very significant as far as that. And we can do that a couple ways. We can drop the head of the first with something like a first ray cutout, or we can raise 2 through 5, which is what they did in this particular case. This kinetic wedge device does that. And Scott and I will talk about, we do something similar. We make a few little mods to the kinetic wedge, and we don't actually use that product. We just build our own in the lab as far as doing that. But when we're walking, we have the rockers. You have heel rocker, ankle rocker, and forefoot rocker. And of course, the Hallux is super important at forefoot rocker. We need, you should have 50 degrees of Hallux dorsiflexion to really be able to walk normally. Once it gets less than that, we have to find a way around that joint which will not extend appropriately. So you could do that with a rockered shoe, or you can change the position of your foot by either externally or internally rotating the foot and peeling off the inside, which is most common, but sometimes the outside of the foot if you have a supinated foot, to get over that first and be able to move forward. Of course, to have high gear push off, we need that first to be down on the ground. Otherwise, it's considered low gear and less mechanically efficient because the foot will be in a pronated state, not a fully supinated state. This study was interesting. They took asymptomatic individuals, 16 guys, 14 women, and basically measured with this digital force gauge. Scott's got a picture of it. At some point, he can flash up there. They used this digital force gauge to basically raise the toe up, sort of passively, to, of course, it has to be a little bit of active because you need a little energy to do that, but it wasn't like it was forcing it up into that position, and then just measuring how much force that was taking. And with this particular device, which you can see below, which basically, like I said, it's a reverse Morton's extension, so you're raising 2 through 5, drops that head of the first down, moving that axis ventral and anterior of that first MTP, which allows that Hallux to dorsiflex, provided the range of motion is available. And these were asymptomatic individuals that were in this particular study. So we weren't looking at people with first MTP pain. And, I can tell you it works with people with first MTP pain, provided they have some degree of dorsiflexion available. And we've talked about it before, where you can just take the distal first, basically place your thumb under the proximal end of the first, place your finger on the distal first, so raise up the base, drop down the head, and then just simply dorsiflex the toe. If that increases over where it is neutral, or if they're weight-bearing, there's a good chance something like this is going to work. If not, then you're looking at putting them in a rockered shoe or something like that. So we need that dorsiflexion during terminal stance phase for us to be able to ambulate and move forward.
I think the reverse Morton's, the best way that I can kind of visualize it is the reverse Morton's provides less resistance of the first MTP into dorsiflexion, and that's really what that device was really measuring is the resistance into dorsiflexion as it pushed it up, how much force was it generating back down into it, right? So it was able to greater emphasize that range with probably applying less resistance down into it. So it just creates a better mechanical advantage for the way that I see it.
Yeah, and remember at that phase of the gait cycle, from mid-stance on is really when the foot intrinsics shine, and they're starting to do their job, and they're not only providing proprioceptive feedback to the brain, but they're also applying a compressive force to the joints, making the foot more compact and more easily supinated. In addition to that, we've got, of course, the pronis longus, which is going to be firing, helped by the brevis and the tertius if it's present, to try to get that first ray down to allow some of that motion to occur. And then we've got long flexor activity at that point, which aren't acting as much to flex the distal aspects, but more to flex at the MTP and create stability as we're starting to come over that. So it sort of shores up and makes the foot somewhat more rigid and compact. So that's all part of the windlass mechanism. We've talked about that plenty of times before on podcasts as well as in seminars and stuff that we've written. So super important to ensure that that's there, and it's something that you really need to look at. And you not only want to look at it when they're off weight bearing, but you want to look at it when they're weight bearing as well. And then you can do the effects of, you can stick a kinetic wedge in, you can stick a medial post in an arch, and then measure that hallux dorsiflexion again to make sure that that's increasing. A lot of forefoot posting raises that first MTP axis dorsally and posteriorly, which limits the motion. And people that have had that chronically develop that little dorsal exostosis over the distal end of the first, which over time is going to limit the amount of dorsiflexion that's available. Scott, we were talking offline before here. You like to modify this. Why don't you talk a little bit about how you modify a kinetic wedge type device? And you don't have to go buy the kinetic wedge, for wherever you can buy it from. You can just get some 70 durometer EVA and cut them yourself. You could probably use multiple pizza boxes glued together if you wanted to, depending upon how rigid you want the device, but something that's going to be in there. You want to be careful extending that too far distal under those met heads, because if they don't have enough forefoot rocker or ankle rocker, they're going to force those met heads into the ground, and then you're going to give them a metatarsalgia. So that's something we need to be careful of.
Right. Well, what I've done sometimes is I've really created, like if I'm really trying to offload in some cases, the first, what I will do is I'll create almost like a reverse Morton's with a varus wedge or a medial wedge from 2 to 5 to really try to roll them off it. And again, you're not really getting great high gear push off in that manner. So again, it's not something I would do for somebody with a normal foot mechanics, but it's if somebody's got a painful foot that I'm trying to offload, that's one of the ways in which I try to accomplish that, by trying to also maintain somewhat of a normal gait mechanics. But again, if somebody's got a painful foot, sometimes normal gait mechanics isn't what you're looking for anyway, because normal may bother them. So it's just an offload strategy that I sometimes utilize to facilitate taking some pressure off of that first.
And, we've, on the other case too, when we're trying to get people to be able to dorsiflex the first more, we'll use a similar strategy, but we'll valgus post it. So we'll grind it from medial to lateral. We'll grind more off the medial side. So that's going to force them down into that first. But you have to be super careful that they have adequate motion in that first MTP, or you're going to light it up. And then they're going to be really upset, and they're going to throw it at you when they come back into the office and not be happy. But yeah, other than that on the article, I don't really think, Scott, that there was a lot. One shows the efficacy of a reverse mortis and the importance of that first MTP motion. We did have a short video that I shot a while ago at a seminar that I was teaching. It was actually a trigger point dry needling seminar, but I go into first ray mechanics. We've got that here, and I thought we would flash that up and kind of go through that, and then we can do a little discussion after if that works.
Sounds good. Let's go.
Awesome.
So I woke up this morning thinking about stuff. So what are the 4 muscles that all refer pain into the big toe?
Tibialis anterior.
Tibialis anterior. That is the Adante muscle, we're going to call that. We have the Thatcher technique, we have the Adante muscle, things like that. So, okay, good. So the tibialis anterior, what else?
Long head, adductor hallucis.
Not the adductor. Adductor hallucis refers into the heel. What's the other one? The flexor hallucis longus. the extensor hallucis longus and the extensor hallucis brevis, right? So we've got those muscles. Approximately, we don't have to worry about little things. Where do they all kind of attach from where to where? Tibialis anterior attaches anterior tibia to what? First metatarsal base and medial cuneiform. Where does the flexor hallucis brevis, that's on the bottom of the foot, remember third layer, kind of the back of the foot, calcaneal area, comes forward through the sesamoid bones, proximal phalanx of the great toe. Where does the extensor hallucis longus go from? Lateral lower leg, anterior to the toe, to the top of the toe, distal phalanx, right? Where does the flexor hallucis longus go? Superior aspect, fibula, right? Lateral side, comes down and across, distal phalanx of the great toe, right? All those guys refer into that area, right? So keep that thought, like just put that on the back burner for just a second.
And you said the extensor hallucis brevis was into the metatarsal head.
Proximal phalanx. Mm-hmm. Put that on the back burner for a second. Now, what is the definition of an active trigger point? It is firing when? All the time, right? It's allodynia. We talked about that yesterday, right? It's always on. That's an active trigger point. A latent trigger point means I have to press the muscle to do it, right? A satellite trigger point means that it's in a different area, and when we press one, we get pain ancillary to the primary trigger point. Think about if people are having pain in that first MTP. More than likely, with that great toe pain, the pain's coming from the first metatarsal phalangeal joint, right? Okay. So the first metatarsal phalangeal joint, I've got the metatarsal bone that comes down, right? And then I've got the phalanx, which is here. So the first met comes down, the phalanx is right here. Okay. So normally what has to happen is the axis of motion of this joint has to go ventral and anterior. And as that goes ventral and anterior, what that does, you can see by sinking down, is it allows that great toe to dorsiflex, right? When the axis of that joint moves dorsally and posteriorly, that limits the hallux ability to extend. And we talked about that yesterday about being able to progress and get over your great toe, right? So ventral anterior is what it's supposed to do. Dorsal posterior is what we don't want it to do because it limits the motion. When you have pain in the big toe, a lot of times it's going to come specifically from this region. What do all those muscles have in common? All of those muscles influence dorsal posterior or ventral anterior motion of this metatarsal phalangeal articulation. Do you think it's possible if people have a latent trigger point? Now, okay, so put that thought on the back burner. When I treat a trigger point, how long does it take for it to get better? Is it instantaneously better, 100%, or does it take a little bit of time for it to get better? Usually. A lot of times it's going to take a little bit of time. Do you think it's possible that the pain in that joint is actually maybe due to dysfunction of those muscles rather than necessarily trigger points in those muscles? And if I normalize the function of those muscles, I normalize the function of this joint, and the pain that we're getting in that joint maybe isn't necessarily from the trigger point per se, but more from the dysfunction arising from those muscles, and we're getting sclerotogenous pain. Will you agree with me that some of trigger point pain probably comes from the connective tissue element of a muscle? Probably. I mean, we don't know for sure, right? We can look at Dave Mentz's work and some of Travell's work, and they talk about some of that with all the different nociceptors in muscle and in the connective tissue. So it's certainly very possible. So my theory is that because all of those muscles cross, because if you look at, you say, oh, well, they are all innervated by the same segmental level. Okay, so then why, when I get irritation of L5 and S1, does it not always irritate my big toe? So it's not just segmental innervation. There has to be another component there. So I'm thinking that we're probably dealing with some kind of sclerotogenous pain, and because all those muscles influence the axis of this joint, if I needle them, now needling will improve function pretty immediately, and it may take several days for those symptoms to actually go away and for that patient to restore some of that range of motion. Does that kind of make sense? Yeah. So anyway, that was one of those things that was bothering me. I was kind of trying to figure out, like, well, why is it not, why are these referring to this specific area? So it's always good to understand. So anyway, that was my
Very, very cool. So
Yep.
I think it just speaks to the fact that compression around the joint will obviously limit the function, and therefore we need to identify what is causing the compression at that joint or the poor arthrokinematics of that joint, and whether that is truly joint related or is it something that is soft tissue related around the joint that stabilizes it or excessively stabilizes it in a certain way.
And remember, there's lots of ways to skin the cat, right?
Mm-hmm.
So we like to use orthotic therapy quite a bit. So something like a first ray cutout or something like a kinetic wedge or reverse mortise in this particular case, along with appropriate mobilizations, exercises for those muscles specifically, particularly the ones which descend the head of the first, which are going to be like the pronaos longus, the extensor hallucis brevis, to some degree the short flexors because they raise the heads dorsally on the opposite side. Those are all going to be super important. So just one more tool you can have in the toolbox when you're treating these people with first MTP pain. And remember, a lot of times that's going to be the precursor to people developing bunions and HAV and issues like that. So if we can nip it in the bud early, then it's not going to be a problem.
It also talks to our philosophy of really stabilizing the arch from the sustentaculum tali and actually elevating it more proximally and allowing, to the best of our ability, that first MTP to really stay dropped.
Exactly.
Yeah. Cool.
All right.
Anything else you want to add to this?
That's it. I think we've probably said enough. Thanks, guys.
Take care, guys.
All right. Take care.